Just keep on striving and don't lose your fighting, even when it's dark and you're alone. Don't ever give up. No, don't lose your hope. Just look up above, the sun is rising, a new dawn. Just keep on striving and don't lose your fighting. Don't give up, now know.
Welcome back. Wow, what a powerful opening to what I anticipate will be an incredible next couple of days. As we transition into the next part of our program, we want to set the scene, if you will, for a general overview where we present data and targets. I often say that this work that we do at the intersection of faith and HIV is work at the intersection of statistics and stories. Jeannie White so eloquently lifted up the importance of stories and how we can sometimes get preoccupied with the numbers, but we also acknowledge that the numbers are important, that the information is important. And so at this time, we want to transition into a period where we receive that information that helps inform the stories that then help us to transform. And so with that, I want to welcome now Vinay Saldana, who is Director of UNAIDS WDC, who will provide for us an update on the state of the HIV and AIDS global response. Vinay.
Thank you, Ulysses. And let me begin by really paying sincere honor to the amazing heroes of the faith community in the HIV response who are with us today. To Reverend Canon Gideon, to Reverend Pauline, to Father Bob Vitello, to Father Richard, and your powerful call for radical hospitality. The work that we do is inspired and lifted and kept on track thanks to your counsel and your support and your guidance. You and others have provided thousands, if not millions of people living with HIV and HIV activists with the power of prayer and faith when we needed it the most. Thank you. I also want to take a moment to pay special tribute to Jeannie White. I think she had to leave the room for a moment, but I've worked in HIV for some time. I think it was 32 years ago this year that Ryan White passed away. I've been doing work in HIV for 30 years, and I've never seen such a powerful, moving master class on how to confront and end stigma and discrimination from 30 years ago than what Jeannie was able to share with us today. So thank you to her and to her family that keeps the memory and the legacy of Ryan White alive and powerful as when he was still with us. And separately, I'd like to recognize the amazing leadership from the PEPFAR team, and in particular from Sandy Thurman. I started working much more closely with Sandy when I moved to the United States just a few months ago, and I quickly realized that there is no stronger leader of faith in Washington, D.C. who preaches a powerful sermon every day that we will not end AIDS anywhere until we end AIDS everywhere, including in the United States. Thank you. So as highlighted by my colleague Matt Cavanaugh this morning, I'd like to share just a few highlights, some rather concerning highlights from the launch of our Global AIDS Epidemic Update. You can join online this afternoon at 2:30. And since the previous pre-conference 2 years ago, we don't see just one crisis in the AIDS pandemic. We see multiple crises and multiple pandemics that are overlapping with each other, creating actually the title of the report, In Danger, which is not only where we find the global HIV response, but also where there are some positive and hopeful opportunities of strengthening the HIV response by making much more clear and explicit links with the success stories, including success stories in work with the faith community. So let me start with some of the new data. And yes, it feels like a little bit of a tsunami of frightening numbers and statistics. And as Brian said this morning, for me it's like a little bit of a crisis of faith, but we are not preaching fear, we are preaching hope in the HIV response. But if we really focus on the numbers and the overall trends, progress towards ending AIDS has indeed, especially in the last couple of years, been faltering. Resources have been shrinking instead of growing. And the inequalities and inequities that every community, every city, every country face at a time when they should be narrowing or ending are in fact widening. And we see this across the range of indicators, across the range of data sets. But of particular concern is that there are now insufficient investments. There's simply not enough money being mobilized and smartly spent to end AIDS by 2030. And as a result, we are facing millions of avoidable AIDS-related deaths between now and 2030, and millions more of new and avoidable HIV infections if we continue on the trajectory that the world is on now, or at least was at the end of last year, 2021. But the report that you'll see this afternoon really does end with several messages of hope and resilience and a rather urgent call to action. First, that yes, we can end AIDS by 2030, as promised, as communities, including faith communities, joined. And thank you for your support to UNAIDS and to the UNAIDS PCB in pulling together one of the most ambitious global AIDS strategies that has ever been developed in the history of UNAIDS, and then moving it from UNAIDS to, and our board forum, to the UN General Assembly in June 2021, almost exactly a year ago, when as a high-level meeting political declaration it was adopted by the member states of the UN General Assembly. But the bad news is that in 2021, we had approximately 1.5 million new HIV infections. And that is over 1 million more than the global target. In too many countries and for too many communities, we now see an alarming trend towards rising numbers. Not simply that the numbers of new HIV infections are decreasing, but decreasing at a slower rate. We also see that in many countries and many regions. But we see a growing number of countries and communities in which we see a rising number of new HIV infections in the same places where all countries and all communities need to be working towards not just declines in HIV infections, but rapid declines in HIV infections. We also see very stark inequalities and inequities, both within communities, within countries, and between regions. And these inequalities and these inequities are really stalling the HIV response and the impact of HIV, particularly in humanitarian crises, for migrants, for people stuck in civil wars, for people in Ukraine facing a massive conflict, and unfortunately not the only conflict that the world is facing today. We see how HIV is both being worsened by these conflicts, and HIV is also further exacerbating these inequalities. In 2021, every 2 minutes, an adolescent girl or young woman was newly infected with HIV. COVID, as we know, for the last 2.5 years, led to extremely challenging disruptions to key HIV prevention, testing, treatment, and support that is essential to ensure viral suppression for all people diagnosed with and living with HIV. And COVID made it particularly worse for some of the most vulnerable and at-risk individuals and populations, in particular with unprecedented numbers of young women and boys who are out of school and spikes in teenage pregnancies and gender-based violence. In 2021, the AIDS pandemic took another life every minute. Over 650,000 AIDS-related deaths, despite the fact that we have all of the tools, all of the technologies, all of the medicines at the right price available to make sure that everyone in the world can benefit from it. The fact that there are an unprecedented number of people diagnosed with HIV and now on HIV treatment is really a tribute to the leadership and the dedication of faith communities around the world in terms of ensuring that people aren't afraid to come forward and access life-saving services, don't face the stigma and discrimination they need to be able to access and benefit from these services, but still these services, access to life-saving technologies, testing, treatment, and prevention technologies, are still not reaching everyone in need. And so in terms of the overall trends of HIV treatment, yes, there was another huge step forward taken in terms of increasing the number of people living with HIV in 2021, but the rate of scale-up of new people on treatment is actually slowing at a time when it should be increasing. Now, it's not easy when you get to a certain level or what we would call a critical mass. It becomes harder to identify the people that still haven't been tested. It becomes harder to address the legal and stigma and discriminatory barriers that people have to step over or still encounter that prevent them to come forward from accessing these services. So while we should, as a global HIV community, be very proud that now 3/4 of all people living with HIV in the world have access to antiretroviral treatment, approximately 10 million people living with HIV still do not. That is a huge challenge that not only UNAIDS or PEPFAR or the Global Fund or UNITAID or this or that bilateral donor or any national government or national AIDS commission can take care on our own. This is a huge challenge, and it's a life-threatening challenge for every single one of these 10 million people living with HIV who not only still lack access to life-saving antiretroviral treatment, but many of them don't even know that they are living with HIV. So special thanks to the partners in this Interfaith Preconference for your excellent 12 million campaign, which has provided outstanding results and impact. But even these results, there is still more work to be done to get us on track from delivering breakthrough results to being absolutely sure that every country and every community is on track to end AIDS by 2030. And you'll see these data in the report this afternoon. At the end of last year, in 2021, only half, 52%, of children living with HIV had access to life-saving antiretroviral treatment. And in fact, the inequalities and inequities in access to HIV treatment, comparing adults to children, is actually increasing rather than narrowing. So this is a very practical and very concerning example of the kinds of inequalities and inequities when even children do not have the same access to life-saving treatment that adults benefit around the world from. And amidst these overlapping and reinforcing crises, we also see a very concerning divergence and range between countries, within countries, and pockets of epidemics of particularly amongst key populations when 2/3 of all the new HIV infections are occurring amongst key populations, not amongst the general population, with the trends of new infections amongst key populations, even in sub-Saharan Africa, actually on the increase, whereas amongst the general population, in most countries, they are now on the decrease. So we have been able to also identify, and you'll see these examples and case studies in the report, a number of very positive examples of communities, of countries that are on track to end AIDS. They have reached, according to the PEPFAR definition, epidemic control. They are on track to reach the 2025 targets. They are on track to end AIDS by 2030. But we need every country to be on track to end AIDS, because we do not end AIDS everywhere until we end AIDS in every country and every community. So please take the time to not only celebrate, but also encourage how do we replicate those examples of success in the countries that are on track to those other countries and the other communities where we as UNAIDS or as PEPFAR or as the Global Fund may not be well set up, but as faith communities, you are everywhere. And how do we make those connections? How do we expand what is working and not take 5 years to do it, not take 10 years to do it, but have conversations this week here in Montreal on how we take that work forward? I won't go into the details of some of the other very concerning red flags raised in the report, but they include how some of the very painful lessons around hoarding of vaccines for COVID have really cost the lives of too many people, particularly in low and middle income countries. And now we have a new, extremely alarming outbreak of monkeypox. And our hope from the UNAIDS side, you might have seen the statement we put out earlier this week on monkeypox, strongly in support of the WHO determination of monkeypox as an urgent global health concern, that we risk to face some of the same challenges around access to monkeypox vaccines that we faced for the last 2 years and access to COVID vaccines, and that we continue to face in HIV to life-saving services for prevention, treatment, care, and support for HIV. And let me just provide one other very alarming statistic from the report. At a time when international solidarity and support is needed the most, we see global solidarity in terms of international funding trends stalling, and in many countries, in fact, even in reverse. What we call ODA, or Overseas Development Assistance, which is measured in terms of US dollar terms, specific to HIV from bilateral donors, over the last decade, has actually decreased by 57%. And the only country which we strongly recognize as having continued to stay the course, hold the flag, and continue to not only maintain but even increase bilateral and multilateral resources for the global HIV response is the government of the United States. So special thanks to US leadership for really demonstrating how important it is to not only talk about ending AIDS, but it needs to be fully funded, and not only by the US government, but by all countries and partners equally. So we talk about ending AIDS by 2030. And we've actually put some numbers, you'll see them in the details of the global AIDS strategy that was adopted last year, on how much it will cost. And we've put a figure, and the figure, you can actually break down the figure in terms of how much the different components of this figure of $29 billion per year, which is needed to end AIDS every year between now and 2025. And actually, if we mobilize those resources, things start getting cheaper because we've reached a critical mass, and the number of people that need to be found and then put on treatment becomes significantly less after 2025. But there is something else that can be done that doesn't require billions of dollars or millions of tablets. And that is a very powerful lesson from the faith communities that are united in this pre-conference, Interfaith pre-conference. And that is the power of treating every individual with love, dignity, and support. Because to effectively fight against stigma and discrimination actually doesn't cost billions of dollars. It costs nothing. It's free, which is what makes it priceless. And so I would hope that more of the international partners and national partners that are engaged here in Montreal this week in a historic effort to start focusing on how we move from a plan to move to implementing the plan to end AIDS by 2030, realize that addressing stigma and discrimination and taking an example from faith communities is one of the best investments we can all make. Thank you very much.
Thank you, Vinay. At this time, I'd like to welcome somebody who we all know, Francesca Marico of UNA's PEPFAR Initiative, to provide a general overview of the PEPFAR Faith and Community Initiative.
So good morning and good afternoon, everyone. It's really a pleasure to be here. To stand together with you against stigma and discrimination. I also want to say and offer special greetings to the people who are online and also those who are following us at the airports, because a lot of our friends are still stuck in different places around the world. And we have now about 200 participants joining us virtually, so a special thanks to them for being with us. So I am a people person, but I was asked to talk about data, so I don't know how good I will do it. But so the presentation today is really about the data on HIV, stigma, and discrimination. I'm going to say something about the targets that have been set by all United Nations member states, and I want to talk about some of the actions of the faith groups, especially those engaged in the UNAIDS PEPFAR Faith Initiative and in the PEPFAR Faith and Community Initiative. So you see here in the presentation that, and it has been said by many, that stigma and discrimination limit access to the HIV response at all levels. And they limit access to prevention services, to health services, to testing, treatment, adherence, and viral load suppression. But I was really wondering if everyone here present and those following us virtually know really what's the difference between stigma and discrimination, because this is important. And being a lawyer, for me, words means a lot, because discrimination is a human rights violation, and stigma is this dynamic process of a devaluation that discredits a person. And HIV-related stigma is multi-layered. It builds upon the association of HIV and AIDS with some of the behaviors that are already marginalized, for instance, drug use. And this also reinforces the fears of the others and vulnerable groups or key population groups, for instance, prisoners or migrants. And self-stigma is when a person living with HIV internalizes the negative responses and reaction of others. And so here we come to discrimination. And so when stigma is acted upon, the result is discrimination, which, as I said, it's a human rights violation. And discrimination consists in actions, but also in omission, in the lack of actions that is derived by the stigma. And it can take place in families and in communities, and we have heard a lot of examples today. But also it takes place in institutional settings, and it takes place in places of worship and faith communities. There are several examples, but because of time, I'm not going to go through them. Just what I wanted to say that on the Interfaith Health Platform website, you're going to find all the presentation and also all the recordings of the different sessions of these days. So here are the data. The Stigma Index study, which is led by the Global Network of People Living with HIV, indicated that HIV-related stigma and discrimination, The Stigma Index study that, as I was saying, is conducted and run by the Network of People Living with HIV is reporting that discrimination is causing or contributing to job loss in more than 50% of cases in 7 of 11 countries with reported data. And in 11 countries with available data, up to 40% of people living with HIV report being forced to submit to a medical or health procedures. and up to 21% of people living with HIV reported being denied health care in the past 12 months. We have also as information that up to 26% of women living with HIV reported that receiving HIV treatment was conditional on taking contraceptives. And still, 47 countries maintain travel restriction for people living with HIV, and people from key population face high level of stigma, discrimination, and violence. And more than 50% of people between the age of 15 and 49 in 25 of 36 countries with recent data hold discriminatory attitudes towards people living with HIV. What we know is that if people living with HIV perceive high levels of HIV-related stigmas, are 2.4 times more likely to delay enrollment in care until they are very ill. And for adolescents living with HIV, experiences discrimination from other students or teachers influence their ability to adhere to treatment and manage a dosing schedule at school. So we have heard Vinny before and others talking about the Global AIDS Strategy 2021-2026 and making reference to the political declaration on HIV and AIDS, which is entitled Ending Inequalities and Getting on Track to End AIDS by 2030. So both these documents confront stigma and discrimination, and they affirm that confronting stigma and discrimination is a prerequisite for effective prevention and care. And they reaffirm that discrimination on the grounds of one's HIV status is a violation of human rights. These documents identify very specific commitments by all UN member states, but also they have identified specific targets to be reached by 2025. So some of these targets are included here in the slides. Less than 10% of people living with HIV and key population experience stigma and discrimination. Less than 10% of countries have punitive legal and policy environments that lead to the denial or limitation of access to services. And then less than 10% of the general population reports discriminatory attitudes towards people living with HIV. And here we come to our conference. And what I wanted to tell you is the way the core group, the planning group of the Interfaith Preconference decided to shape the program is to make sure that each of the sessions was following the specific commitments that are included in the political declaration. This because, as was mentioned today by Reverend Kanu Gideon, we want to recommit to eliminate HIV-related stigma and discrimination. These documents, as I was referring before, indicate that all countries are committed to create an enabling legal environment which aim to ensure that less than 10% of countries have restrictive legal and policy frameworks that lead to the denial or limitation of access to services by 2025. And what we have heard is that only in partnership we can reach this target. So it's really important that the religious leaders and faith-based organizations support the creation of such enabling and a legal environment. And for this, again, today we have been hearing a lot about this Interfaith Health Platform and the 12 million campaign. What we believe is that it's really important that we come together as interfaith groups in coordinated advocacy and actions. And one example, again, is the 12 million campaign, which now I'm really pleased to hear that is going to be the 10 million campaign. So I hope that by tomorrow we're going to be able to make all the changes. As we have heard, we have now made a lot of progress in having children, women and men on treatment, but we still have 10 million people who are not having access to treatment. So, and we know that a lot of these people are from key population groups or are the most marginalized. And so it's really important that faith leaders and communities come together to ensure that everyone with HIV has a long and healthy life. And just to say a bit more about this campaign, And again, you can go on the Interfaith Health Platform website. You have the link also on the left on the banners. What we are asking faith leaders and representatives of faith community is to endorse this campaign and to identify, just up to now, 12 members of their faith communities to join the campaign. And the purpose was to make sure that information about HIV prevention, testing, and treatment, and the value on testing and treatment were spread in the faith communities. So now we are going to ask each individual who is endorsing the campaign to identify at least 10 people. And so I really ask everyone who is here who has not yet done so to sign the campaign on the website. Another important initiative is the PEPFAR Faith and Community Initiative, which was launched in 2018 with the purpose to address key gaps towards achieving HIV epidemic control and ensuring justice for children. So engaging faith communities and faith leaders to address also, to reach children and men, but also to address sexual violence against children. And with a large number of faith leaders, we have been working during the past years to develop communication prototypes, which include messages of hope on HIV and messages of hope on COVID. And on the slide, you can see some of these prototypes. But again, I would invite everyone to visit the Faith and Community Initiative website, where you can find a lot of materials. We really share these messages of hope. They are combined with prayers and sermons and reflection by faith leaders, both from the Christian communities and the Muslim communities. And they have been spread through social media, also during the time of COVID. And the reason is really to make sure that people are informed about HIV, because unfortunately there is still a lot of ignorance in spite of the technological advances, and to bring this message of hope that there are tools available now to live a good life. As I was saying, the entire pre-conference is set up around the commitments of the political declaration and the targets of the AIDS strategy. So as you can see, we want to make sure that we involve and we hear the voices and recommendation and vision of people living with HIV, but also of young people. So after this session, there's going to be a session specifically on this. We're going to have several workshops. And the workshops are going to share about models where faith groups and faith leaders have been implementing stigma reduction intervention in different parts of the world. We are going to then have a session on the faith and community engagement, leveraging trust and access to sustain epidemic control and advanced prevention. But what I wanted really to focus your attention on is a series of sessions that we are going to have tomorrow morning. Before, someone made reference to the potential of undetectable, equal, untransmittable message. And I think that faith leaders and faith community really need to do more to make sure that this message, which is really a message of hope, is spread in our communities. Even the global AIDS strategy includes the importance of leveraging the potential of this message. So tomorrow we are going to have a series of sessions where we are going to talk about innovation to tackle HIV stigma and discrimination. We are going to talk about the message of you equal you, and we are going to have here as guests a series of representatives from different organizations. We are going to have the Elizabeth Glaser Pediatric AIDS Foundation, CHAI, the Clinton Health Access Initiative. We're going to have representatives from the World Health Organization. But also we are going to hear by representatives from faith communities who are going to share about the ways that they have been implementing these new technologies, new tools, to make sure that we offer comprehensive and then compassionate care to all. And then finally, tomorrow, we are going to look at also the monitoring and evaluation framework and how these existing frameworks that are applied in other settings to track the progress on stigma and discrimination can be used in faith communities. So this is really what the core group put together, and we put together all these 2 days of conference and the different sessions with the aim to come up with very specific actions that can be implemented after the conference. So we hope that this conference is not going to just be a discussion and a series of sessions that for these 2 days, but are going to take longer. They are going to continue, and that we are going to bring not only in our arts, but in our days action when we are going to go back to our faith communities in countries. And thank you.
Next, we will be joined virtually by Christine Njogu, who's Program Officer of Faith Sector at the National AIDS Control Council in Kenya. I want to reiterate Francesca's comments that many of our colleagues, including Christine, had planned on being here in person, but have been unable to do so because of visa challenges, and we want to make sure that we continue to lift them up and know that they are missed, but also know that we are grateful for their engagement in this way. And so now we will welcome Christine, who will give us an overview of country's situation and challenges, gaps, and interventions.
But it's a target that we believe we'll be able to achieve by the year 2025. And we have brought on board the faith sector to help us reduce new. My name is Christine Njogu. I work with the National AIDS Control Council in Kenya. I'll be making a presentation on stigma and discrimination, the gaps and interventions by the faith sector in Kenya. I'll be looking at the journey of HIV and faith, the mandate of the National AIDS Control Council, our HIV situation as a country, our role as the interfaith in the HIV response in Kenya, and gaps and opportunities. As a country, we started by approaching HIV as a moral issue. People living with HIV were labeled and isolated, and this led to increased incidence of stigma, more infections and deaths, number of orphans and widows increased. As a country, we were facing a pandemic, and the National AIDS Control Council was established to provide leadership and coordinate the efforts of all stakeholders in the HIV response. And this is through development of strategies and policies, and also mobilizing stakeholders, including the faith sector, to respond to HIV prevention and management. So as a country, our AIDS strategic framework specifically identifies reduction of HIV-related stigma and discrimination as an objective that we need to achieve by the year 2025. And as the Interfaith, we are supporting the achievement of the objectives of the Kenya AIDS strategic framework through our AIDS action plan. And part of the action plan includes development of information to build capacity of the interfaith. So as a country, we have a gap in reduction of new HIV infection. We've not been able to achieve our target of 75% as at 2019, but it's a target that we believe we'll be able to achieve by the year 2025. And we have brought on board the faith sector to help us reduce new infections, especially amongst the young people. And this is because the faith sector has institutions of learning and big fora through which advocacy and dissemination of information happens. They have a wide reach in every part of this country. You'll find a place of worship. The faith sector provides 40% of healthcare in our country. Religious leaders are held in high regard and have high influence. The Interfaith has media houses through which information is disseminated to populations. And as a country, 97% of us ascribe to a religious faith. So every Friday, Saturday, or Sunday, we are in a place of worship. And through the faith sector, we are able to reach many populations with information on HIV. And on engaging the faith sector, we are looking at HIV prevention and specifically promotion of abstinence, faithfulness as a HIV prevention method, promoting HIV testing and counseling, comprehensive HIV knowledge, elimination of mother-to-child transmission. We are also engaging the faith sector in treatment and care and support, stigma reduction, and also eliminating gender-based violence and support for orphans and vulnerable children, as well as mobilizing resources domestically for HIV response. So we are engaging the faith sector at 4 levels: community, facility, institutional, and also congregational. And the stakeholders that we are engaging in the faith sector include the religious leaders, faith congregations, institutions of learning, theological trainings, networks of religious leaders living with HIV, faith networks, chaplains networks, the faith media, the faith-based pharmaceuticals and faith-based health facilities, and also the county interfaith networks. Looking at the stigma index in our country, as at 2021, we were at 23.28%, which is a decline from 45% recorded in 2014. Social exclusion reported at places of worship was 1.2, which was lower than 3.57 recorded at the family level. So the faith sector is responding to stigma at workplaces or congregations, and also structural level, looking at laws and policies. So how is HIV stigma and discrimination manifested in the faith sector? One, HIV status disclosure without consent. We also have compulsory HIV test before wedding ceremony, stigmatizing sermons, specific prayers that are targeted at people living with HIV, denial of leadership positions. And what is driving stigma and discrimination? We have misconceptions and misinformation, social judgment, and also fear of infection through casual contact. And this leads to isolation, as well as non-disclosure of HIV status, the fear of testing for HIV, failure to adhere to treatment, leading to feelings of shame and isolation. As a faith sector, we are mitigating or responding to this by building capacity of faith leaders, including those in theological trainings, sensitizing congregations, leveraging on places of worship as service provision points for testing of HIV, and also distribution of test kits, faith-based facilities providing integrated HIV services, clarifying myths and misconceptions, and faith leaders who are living with HIV openly coming out as HIV champions. We also supporting provision of counseling and support to families living with HIV. Networks of people living with HIV are included in HIV coordination and technical working groups at national and county level. We are also building capacity of school chaplains on HIV-related stigma and discrimination, and also dissemination of the HIV and AIDS Prevention and Control Act, which prohibits discrimination against people living with HIV. We still have some gaps in capacity, especially amongst faith leaders in the locally instituted churches. And we also have some religious beliefs that hinder access to HIV and health services. We have some opportunities that we continue to leverage on, including looking at non-communicable diseases. As the aging population of people living with HIV increases, we are experiencing high number of NCDs. So as the interfaith, we are looking beyond HIV to also focus on non-communicable diseases. The other opportunity is looking at the triple threat, which is looking at new HIV infections, unintended pregnancies, and also sexual and gender-based violence amongst adolescents and young women, and looking at the high infections in our country, especially amongst the adolescents and young people, which is at 42%. It is an area that we are leveraging on to be able to reduce incidences of new infections, as well as gender-based violence and also teenage pregnancies. So my appreciation to the Faith Sector Coordination Group and the Interfaith team in supporting the HIV response in the country, to the NAC CEO, and to also the UNAIDS team for their support, and to all the participants in this conference who are joining physically and also virtually. Thank you, and God bless you all.
Excellent. Thank you, Christine. At this time, we will entertain questions. However, in the interest of time, we want to prioritize those questions that come from our online viewers. And so I would kindly ask that you would extend us grace, those of you who are here in person, and if you have questions from this morning's sessions, that you reserve them for those speakers during our break time and sometime later in today. And so if there are any questions from online, I will share them here and invite our speakers to address them as they are directed. We have a question from Gabriel. Thanks for joining us, Gabriel. Gabriel, can you unmute for us? Hi, Gabriel, you have the floor. No sound. All right, Gabriel, we'll attempt to come back to you. All right, no other questions from online? In that case, I will ask if there is one or two questions from the floor. Dave, I saw your hand first. Do I need a mic? I think for the sake of online, we want to always use the mics. You might need to cut it off.
First of all, it's a delight to be live and in person. You know, we can do face-to-face on Zoom, but this is a whole lot better. So I'm thrilled to be here. The question had to do with targets. Francesca mentioned the targets that are in the Global AIDS Strategy, and I would encourage us to think about targets that are specific for the faith sector. And I'll suggest two. One is that the statistics, the HIV response statistics within members of all faith communities, take all faith communities globally, that overall the statistics are at least as good as the statistics in the general population. That's basically saying it's healthier to be a member of a faith community than not. I don't know if we've already reached that target, but that's one that I would suggest. The other is for stigma reduction within faith communities, and that there be enough faith communities that have active stigma reduction programs to make a statistically significant difference, as Ken and Gideon would have asked us to do. I don't know what that number is. Might be 50%. Those are...
Great, thank you for that. We do have forthcoming questions now online. Are we still with Brian Paul, or are we going with Vincent Manning? Okay. Dr. Manning, you have the floor. We can see you. But we can't hear you.
Perhaps the people online can write their questions.
Yeah, let's try that. Dr. Manning, are you able to type your question in the chat? We're having some audio difficulties. Thank you. All right, here we are. Can faith leaders be trained and equipped to carry out tests, especially in rural villages? For example, mine is Bayelsa State, Nigeria. Can faith leaders be trained and equipped to do testing in rural villages? I think the answer is unequivocally yes, but I would defer to those who have experience with that, Father Rick particularly.
Yes, that's an unequivocal yes. I don't have experience in the rural villages, but certainly in the urban inner city. We have pastors that have been trained, and then often trained lay leaders in their community that are visiting the sick as part of their ministry, and then able to do rapid testing, and then if someone's positive, accompany them, and if positive, again, getting them on treatment. So there's a really good there's a really good cascade of finding people that might not necessarily go to a typical, VCT, and then using rapid testing, and then confirming that and getting them right on treatment that we've done throughout Nairobi now.
Thank you, Father Rick, for that firsthand account. Let's take one more question online, and then we will officially close this session. Okay. All right. Well, I want to extend my gratitude to each of the speakers during this session. At this time, we will have a break. Our schedule says our break is for 30 minutes, but I would ask if we could make that 15 minutes in the interest of time so that we can stay on track and eat lunch at a reasonable hour. Thank you. For those of you who are joining us online, we ask that you stay logged on, but simply mute yourself and join us back in 15 minutes.